Okay, we're recording. Hello, everyone, and welcome to another episode of Heart Success Podcast. Today, we're going to do something a little different. We have a much bigger panel today. We have Dr. Janani Rangaswami, we have Dr. Catherine Tuttle, Dr. Mutaya Vaduganathan, and Dr. Vivek Bhalla. You may recognize Dr. Rangaswami and Dr. Vaduganathan because they've featured in couple of our previous episodes. So what we're going to do today is we're going to discuss a recent publication in circulation, really led by Dr. Rangaswami and all the co-authors here, a scientific statement from the American Heart Association on cardiorenal protection with the newer anti-diabetic agents in patients with diabetes and chronic kidney disease. Welcome, everyone. And I was hoping maybe each one of you could just tell us a little bit about you.
Hello, everyone. It's good to be back on the podcast. Thanks, Mahek, for the invite. My name is Janani Rangaswami. I'm a nephrologist with an interest in the cardiorenal space. I run the cardiorenal medicine program at Einstein, and I'm also the vice chair for the Kidney Council of the American Heart Association. And it has been a very gratifying experience to work with these amazing co-authors and thought leaders on this scientific statement. So thanks for having me.
Hi, everyone. I'm Vivek Bhalla. I'm a nephrologist at the Stanford University School of Medicine. And I'm really pleased to be here and be with my co-authors to be able to discuss this publication and this new emerging area in cardiorenal medicine. I do basic science as well as clinical science in my practice. And I am the immediate past chair of the Kidney and Cardiovascular Disease Council for the American Heart Association.
Great. Hello, everyone. I'm Catherine Tuttle. I'm an endocrinologist and a nephrologist. I'm a professor of medicine at the University of Washington and also executive director for research at the Providence Healthcare System. I've been interested in clinical and translational research in diabetes and kidney disease for a long, long time. And it's really very exciting to be at this point where we have some breakthrough therapies that really are poised to improve outcomes for patients. And those include both heart and kidney outcomes, which so commonly occur together. So I'm delighted to be together with the panel and to have had the opportunity to participate in this important scientific statement from the American Heart Association.
Thank you, Mahek, for having us. Muthu Vaduganathan, I'm a cardiologist at Brigham and Women's Hospital and Harvard Medical School. I'm a clinical investigator focusing mostly on heart failure, epidemiology, as well as clinical trials. Very excited to be a part of this group. We've worked hard over the last couple of years and gotten to know each other very well. And I think that we're excited to discuss these therapies specifically that really sit at the intersection of our fields.
Thank you, everyone, for joining us today. And it's great to have a faculty that sort of spans across multiple specialties. So this is truly a multidisciplinary statement and discussion today. Next slide. Okay, so I think the objectives sort of, and what I'm going to go over is sort of 10 to 12 slides detailing sort of key aspects from the paper, and then I'll let the panel elaborate on some of those slides. The objectives of this statement were really a collaborative care model, bringing together cardiologists, nephrologists, endocrinologists, and primary care doctors. Focuses primarily on CKD and type 2 diabetes. And we'll be talking a lot about some of the newer agents, the SGLT2 inhibitors and the Glp-1 receptor agonists. So Dr. Rangaswami, I was hoping you could tell us sort of the need for a statement like this. Why does it need to be multidisciplinary? And the objective of coming through with this idea and this statement.
Thanks, Max. So the reason for the scientific statement was mostly to provide a comprehensive summary of some of the more recent cardiorenal protective therapies that have emerged after a long drought, particularly on the nephrology side, for therapies that were truly disease modifying. In the last couple of decades, the field of nephrology really was at somewhat of a standstill. After the last couple of trials, IDNT and renal assured in RAS inhibition as a standard of care in patients with to slow down kidney disease progression. And after that, we've really never had any major therapies that have changed the burden of end-stage kidney disease and dialysis needs and transplantation. Similarly, when you also think about all the standard of care therapies that are implemented in our population of patients with kidney disease, including blood pressure control, glycemic target achievement, lipid therapies, and so forth, there still remained a large unmet need in terms of reducing adverse cardiovascular events as well as mortality. And now we are at this place where there is rapid emergence of high quality data from very well conducted randomized controlled trials, particularly focusing around the two drug classes that you mentioned, the SGLT2 inhibitors and the GLP-1 receptor agonists. And now more recently, we also have data on selective MRAs and their benefits in diabetic kidney disease. So it became necessary to kind of collate all this and provide a comprehensive summary of where the field is, particularly targeted, I think, at the practicing cardiologist, nephrologist, internist, and endocrinologist. And this was felt to be one of the high yield areas. And this was supported by the American Heart Association. And that's how the statement happened.
Okay, thank you. And, like you said, does this, now that we're learning more and more about these two drug classes, and, this is truly novel. I mean, I would let Dr. maybe Tuttle and Dr. Bhalla sort of walk us through how in the last 5 years, we have two new drug classes, all these trials. So it is relatively new to the field, and sort of how much we've progressed in these last 5 years.
Dr. Tuttle, do you want to take that first?
You're still muted.
Unmuted. Yeah, I would be happy to. Yes, I remember very well when the IMPA-REG outcome results were presented at the American Society of Nephrology. And I think there was a collective breath stop because we really had never seen data like that, even in our very intentional trials of new agents. The effect, even though they were secondary outcomes, was a stunning reduction in risk of not only albuminuria and GFR decline, but true kidney disease outcomes in a population not selected for kidney disease risk. As you all know, these were cardiovascular outcome trials. And while we know that heart and kidney disease occur commonly, in clinical trials, we typically select participants for the risk we're trying to study to see the, if you will, the almost off-target effect, it seemed at the time of these agents was really stunning. But even in that early study, there was a major clue as to how these agents were working, or at least a major mechanism, which is reduction of glomerular hyperfiltration as we looked at the GFR trajectories. And then I suppose the rest has been history. Those data were basically recapitulated across the other CV outcome trials, the Canvas program and Declare. And then we had our first kidney trial report out, Credence, about 1.5 years ago. And I guess one thing I would also reflect on, having been in this field a long time, is we have never had a clinical trial stop before in the entire field of nephrology for overwhelming efficacy. We've stopped trials for safety or futility, but it was stopped early because the Data Safety Monitoring Board said it would be unethical to withhold therapy from the placebo group. This has never happened. It doesn't happen very often in any therapeutic area. And then particularly after we saw the DAPA-CKD results, they reproduced the almost the same hazards ratio of about 0.6, a 40% risk reduction for primary kidney disease outcomes. Again, stopped early for overwhelming efficacy, 2 in a row. And I think with DAPA-CKD, we extended the GFR down to 25, albuminuria down to 200. It looks like these agents are going to work across GFR and albuminuria strata. But the thing that really struck me about DAPA-CKD was the 30% reduction in all-cause mortality. So think about that for a minute, a trial that stops early. If you look across therapeutic areas, let's come up above water and look outside of cardiology, nephrology, diabetology. Find a treatment for any condition on top of the current standard of care that reduces death from all causes by nearly a third. And I'll also point out in nephrology, this drug is not yet approved, but if it becomes approved and it's on a fast track or a breakthrough therapy status, which is a fast track with the FDA, if that's in the label, that's the first kidney disease therapy that will ever have been approved to prevent death. And now I'm going to turn it over to my colleagues, but I'd like the cardiologists to comment on this, because I would submit that even in the entire history of the abundance of cardiology trials, other than beta blockers post-MI, how many therapies have been approved to prevent death? And that is the ultimate endpoint from any condition. So I'll stop there because I'm sure others have a lot to say as well.
Thank you.
Oh, I echo that as well. I note that this timeline is remarkably compressed, and I think it's a really a victory for science in which sponsors and investigators have rapidly pursued threads of initial kind of suggestions from those trials at the far left, and then pursued various avenues in both heart failure and chronic kidney disease. I recall adjacent therapeutic programs that have taken years longer. For instance, the MRAs and establishing the MRAs in heart failure. The first MRA trial was published in 1999 in the New England Journal. Then we had a post-MI trial in 2003. And then it took over a decade. In 2011 was a trial of milder symptoms or NYHA class 2 symptoms. And so that story unfolded over a remarkably long period of time. And so here we have this very accelerated, compressed therapeutic development in which clinicians now are also buying into the rapid, this rapid progress, and buying into that this is clearly a therapy that has multifaceted effects across the body.
So I have a couple of comments about this, in addition to the ones I agree completely with my colleagues. Just to set the stage from what we knew 20 years ago with the idea of reduction of glomerular hyperfiltration being an important target for reducing kidney outcomes after renal and IDNT. For many years, there was a drought, as Dr. Rangaswami said, and then there was a light of hope with bardoxolone and methyl trials that came out in the late 2000s and early 2010s. And there was a lot of hope around the idea of going after an alternative or tangential effect on oxidative stress within the kidney. And the basic science world had mirrored that. And so when bardoxolone and methyl had these unexplainable but positive outcomes, also sort of a side effect from another trial and then adapted in the kidney world, much like this. There was a lot of excitement around trying that. And then in the eventual phase 3 trial, that drug failed and was stopped early due to safety events. And that really halted progress in the diabetes field. I remember being at that report in 2012, and it was like going to a wake, because we knew that there was this very new therapy that was going to have a huge impact in our field, and it was stopped because of safety. And there were a lot of reasons for that, but that sort of preceded this tsunami of clinical trials that have really come out in the last couple of years. I also think that this is a testament to basic science and NIH-funded basic science, as well as collaborations with industry. So if you go back to the late 80s and early 90s when sodium glucose co-transporter was actually cloned, and Ernest Wright would have worked in this field for a generation without too many other partners. Nobody else was focused on SGLTs as a therapeutic area. And so he worked on the physiology of this. And at some point, somebody decided that this was going to be a good medicine for diabetes. And it really took the pharmaceutical industry to be able to take a non-selective SGLT1 and 2 inhibitor and be able to turn it into a selective SGLT2 inhibitor, which was then adopted by a number of companies that then all in parallel started these clinical trials. And then one after the other have shown a very similar benefit or a class effect. So I think it speaks to a lot of things, but I also think it speaks to the basic triumph of going from a basic finding that was predicted before all these clinical trials, that was shown in these clinical trials. But then also the pharmaceutical industry, I think, really got on board with the idea of targeting SGLT2, and that's why so many of these trials have come out in tandem.
Thank you. And as you can see, there's a lot of upcoming data too. So we have 4 more years of a lot of big trials coming along. So I was going to start with the SGLT2 inhibitors. The slide that I have here sort of summarizes the baseline characteristics and patient characteristics within these cardiovascular outcome trials for SGLT2 inhibitors that focus primarily on cardiovascular and renal outcomes. And I was hoping maybe Dr. Rangaswami, you could just briefly tell us sort of what kind of patients that we've studied in these multiple sort of randomized studies over the last few years with thousands of patients.
Sure. So as you can see, all these are large randomized control trials. There are some notable differences. For example, an EMPEROR outcome, almost 100% of patients had established cardiovascular disease. That number was about half in Credence. And interestingly, if you compare event rates in those trials, they're almost similar. And I think this is the first and important message to take home as a cardiorenal physician, which is, as we well know, but sometimes don't appreciate as much, CKD is an independent risk factor for cardiovascular disease. There are also differences in some of the newer trials, and Muthu is more of an expert in this than I do. When you try to compare the 2 sister heart failure trials, DAPA heart failure with EMPEROR reduced, wherein I think as a nephrologist, one of the things that really struck me was how bold the enrollment was in EMPEROR reduced. In fact, if you take all the SGLT2 trials, and all the data that we have seen in 2020, as a nephrologist, even though DAPA CKD was something that the community was so happy about, if I think about what it actually takes to enroll people with the sickness level at baseline, I think EMPEROR reduced was an example of really taking a particularly vulnerable population and pushing enrollment GFR even as low as 20. And as Kathy just mentioned, in DAPA CKD in Credence, the GFR, the lower limit for inclusion was 30, which went down further to 25 with DAPA CKD and all the way down to 20 with EMPEROR reduced. And I think this is a very welcome trend, which is very different from what Glenn Chertow, another major thought leader from Stanford, called aptly renalism back in the early 2000s, where patients with kidney disease were routinely excluded from cardiovascular trials. Therapies that were proven to be of benefit in the larger general population were particularly not used or underutilized in patients with kidney disease, either for the fear of causing harm or for the perception of utility. And to then go from that end to recruiting EMPEROR reduced, that's a lot of progress, and it's a huge shift in culture. So I think table 1, like Vivek just pointed out, this is a reflection of so many different communities coming together. I think there's also been a full cultural shift in appreciating what it takes to take some of these people with GFRs of 25 with a mean EF less than 30% as the typical patient in EMPEROR reduced would have never been included in clinical trials, even as recently as a few years ago. I don't know, Muthu, I would be curious to hear what your thoughts are, but I was very impressed, especially with how the heart failure community has embraced that very sick cardiorenal patient category.
Absolutely, and fully concur. I think that it is hard to keep slides and publications up to date with the rapid progress. And we have now 10 randomized clinical trials that have spanned the spectrum of SGLT2 inhibitors in these disease entities. 4 in patients with type 2 diabetes with either established cardiovascular disease or multiple risk factors. We have now 3 in patients who have established heart failure. 2 of those were fully populations of heart failure with reduced ejection fraction. We have a most recent one, soloist worsening heart failure, that enrolled patients who are hospitalized for heart failure and randomized either pre-discharge or shortly after discharge. Those patients all had diabetes, but and while the trial stopped early, showed remarkable benefits, even in the about 1,100 patients who were randomized. And then we have 3 trials of chronic kidney disease. So I think we've, I completely agree. I think this spans the spectrum of cardiometabolic medicine with very common threads amongst all these. They're enrolling very high risk populations with high rates of both cardiovascular and kidney events.
Yep. And I was just going to highlight, as you can see, the baseline therapy, ACE inhibitors in the heart failure trials, MRA use was really high in all these studies. So it was really good baseline therapy to begin with in really all these different studies. This is another slide sort of summarizing, overall outcome benefit, putting a lot of these different studies next to each other. And you can see the event rate is quite different, which is what Dr. Rangaswami here was just mentioning. So I was hoping maybe, Dr. Tuttle and Dr. Bhalla, you could sort of talk to how some of the results were slightly different in these trials and how you sort of interpreted it and how you cumulatively put it together as to the benefit of these drug classes.
Well, sure, I'd be happy to take that. I think what you're seeing here, and I think it's a very nice visual, as we've been discussing, depending on the outcome of interest and the population study, there were various differences in event rate, but the direction of effect is similar across disease severity strata. So if we look at the original CV outcome trials, they had lower rates of heart failure, of course, than say DAPA-HF or IMPRA reduced, but still the direction of effect was the same. And I think now we know similarly for kidney disease, is the original trials were almost primary prevention trials, but now in patients with advanced CKD, we see the same direction of effect. It's very consistent. And in post hoc analyses, for example, of Credence that was just published 2 weeks ago, there were actually 174 patients who got into the trial with a GFR less than 30. And their benefit and their safety profile was exactly the same, at least the direction and strength of the effect was on par with the larger population. So that's really sending a strong message too, that these drugs not only prevent heart failure and kidney failure, but they treat it. And we had actually, prior to this, the preventive therapies were not necessarily the same as the treatment therapies. So this is really pointing to something important that somehow has almost been accidentally unlocked. And as a segue to Dr. Bhalla, I will just say that I fully support his comments about the importance of the science to drive the clinical translation. I've also worked on the basic and preclinical science side. This is really unique though, because I think even with what we knew about SGLT2 inhibitors, we did not expect these kind of clinical benefits. So there's a lot more to be unraveled. And that will be critically important in terms of getting more refinement or precision in applying these therapies to different types of patients or at different points in their patient journey. So I'll stop there and Vivek, turn it over to you.
Sure. I have 2 additional comments. I think, Dr. Tuttle, what you're seeing, sometimes clinical trials provide an effect that it takes some statistical machination to be able to convince yourself. This passes the eyeball test in the most pure form, that in every clinical scenario, you saw a comparable effect on the hazard ratio. And I think that this has I have two comments about that. One, I think this has implications for who's going to be prescribing these medicines. We're all familiar with DCCT and EDICT, which is one of the principal initial trials for prevention of kidney outcomes in the diabetic population, and then the type 2 equivalent trials. And they were really about glucose control. And all nephrologists, for example, are familiar with that. All doctors who take care of patients with diabetic complications are familiar with that. But we're also familiar with the idea that those trials showed a benefit in a very early, healthier population than the population of patients that we commonly see in cross-section. And so those types of trials and those types of, that type of progress does not have an effect when you see patients in clinic. This, on the other hand, is very different. We are seeing, when an EMPA-REG first came out, and we were excited about 4 or 5 years ago, and we're thinking that this might be a therapy for our patients that have albuminuria and refractory albuminuria, and had an inexorable decline in their kidney function right before our eyes. We would go to our endocrinology colleagues and we would suggest the idea of an SGLT2 inhibitor. And it was met with some caution because it hadn't been studied in people that were sicker with lower and lower GFR. But as more and more trials have come out and that line has been crossed, we are still seeing similar benefits as patients with more and more renal disease come out. And I think that that's going to be very encouraging. So that was probably the main comment I had about this.
Yeah, thank you.
Just make one other comment, amplifying and my colleague's statements. So if we focus on just the, as mentioned, the directionality is very consistent across these trials. If you take the heart failure trials, for instance, if you take the 10 randomized clinical trials conducted to date, there's a very consistent 30% risk reduction in each of these trials. And that spans the spectrum from lower risk populations like DECLARE, which is type 2 diabetes with multiple risk factors predominantly, to very high risk populations like soloist worsening heart failure, which randomized a population who was admitted with worsening heart failure. So you take I think that also lays out how we'd actually apply these therapies, both for prevention and treatment. DECLARE had an average follow-up duration of around 4 to 5 years, compared with soloist worsening heart failure, which actually demonstrated that same benefit in a very high-risk population in less than a year of average follow-up. Of course, it was curtailed because of loss of funding. But I think that the point being is that when we're taking a health systems perspective on the deployment and integration of these therapies, we're going to be applying these therapies in earlier disease states for longer duration of time to prevent forecasted events. And in addition, really focus on our highest risk patient populations, which we expect to have the exact same relative benefits, but magnified absolute benefits. And really, I think the soloist data was remarkable. I've never seen, absolute risk reductions that substantial. It moved the needle from total events of cardiovascular death and total heart failure hospitalizations from about 75 per 100 patient years down to about 50 per 100 patient years in the treated arm. So the number needed to treat for a year was 4, which is very impressive for a therapy that was with a novel mechanism of action.
So,
I would say one of the things from soloists, from an implementation strategy perspective, I think it makes so much sense to emphasize the inpatient setting as a place for initiation of these agents, maybe even in patients who may not be as sick, but just to use that as one of the strategies to capture these patients. Most of all the other trials, except for soloists, were based on outpatient initiation, but I think this helps us expand our thinking process to include that vulnerable group of patients to break that vicious cycle of cardiorenal syndrome.
Thank you. And I think you already mentioned an important point that came through on a lot of the subgroup analyses, that the cardiovascular outcome benefit with SGLT2 inhibitors really goes across different GFRs and different ranges of albuminuria. I don't know if anybody wanted to add something else to that aspect of care. Maybe, is there a GFR cutoff in your practice where you aren't putting people on SGLT2 inhibitors, at least as of right now? And if there's a drug of choice sort of that you may use for lower GFRs. Maybe Dr. Tuttle?
Sure. Honestly, I think we have to follow the current FDA label. And right now that's for canagliflozin down to a GFR of 30. As we mentioned earlier, we're hopeful that dapagliflozin will get an indication that'll shift to 25 and perhaps even to non-diabetic CKD. And then we heard about IMPA-KIDNEY that could take us to 20. But I think at this point we have to follow the label. It's the right thing to do. And Dr. Rangaswami has talked a lot about implementation. So one of the barriers is actually trying to get the drug for these patients. It's a cost issue, but also our payers haven't yet caught up with these new indications. And a lot of times the patients are required to fail a series of glucose lowering treatments to even get the drug, not recognizing that we're giving them for organ protection. So right now, unfortunately, the implementation hasn't really caught up with the science. I think we'll get there. But it's even hard to get canagliflozin for patients with a GFR above 30. Hopefully that's going to change. Many of us are thinking about models of care, and I had the privilege and pleasure to co-author a paper with Dr. Rangaswami and Dr. Vaduganathan on some ideas about models of care and some things that Dr. Rangaswami has actually piloted at her site. But that's actually our major hurdle now, I think, moving from evidence to implementation. And it's going to take not only education of physicians and patients, but I think honestly, it's going to take some policy level changes to make these therapies more accessible. And I guess the final thing I'll say about the multidisciplinary care models is those need to be resourced, because truthfully, what gets done is what gets paid for. And so even if we pay for the drug, if we don't pay for the care, it's still going to be a barrier. And these patients, as we've been discussing, are often very sick. They have heart failure and they have kidney failure, but many of them have diabetes, right? Hypertension. And then they often are people who have a lot of other problems that are outside of scope, but are still relevant when we have to think about drug implementation, dose adjustments, drug interactions. This is not your 15-minute visit. And so there's going to have to be some other types of changes that occur to make it possible to deliver on the promise of these therapies for our patients.
Thank you. So I think we already sort of went over credence, so I won't spend much time on the renal protective effects of SGLT2 inhibitors. And as you mentioned, there was a significant improvement in the treatment arm to the effect of 30%. And even the primary endpoint was a renal endpoint here. And as you can see, the primary endpoint was end-stage renal disease or doubling of serum creatinine, or renal or cardiovascular death, and the hazard ratio was 0.7, p-values, looks like with 4 zeros before the 1. So very positive trial favoring canagliflozin use among patients with type 2 diabetes and nephropathy. I do want to talk a little bit about sort of the mechanism of action of this drug class, and I was hoping maybe Dr. Bhalla, you could talk us through why we are seeing all these renal protective effects with SGLT2 inhibitors. What is the proposed mechanism of action? And do we really know the extent of our knowledge in this area?
Sure. So I think you actually have a slide a little bit later on that covers that, but I can start the discussion here. So one of the mechanisms of action that I think we do know that SGLT2 inhibitors do, and I want to defer to Dr. Tuttle when we talk about the GLP-1 receptor agonist, but I can start with SGLT2 inhibitors. One of the mechanisms of action that we think is going on is reduction in glomerular hyperfiltration. And part of what we know from that has come from the basic science literature. And if you inhibit an SGLT2 inhibitor, you theoretically will have some distal sodium delivery, which eventually leads to afferent vasoconstriction to reduce glomerular hyperfiltration beyond that of an angiotensin converting enzyme inhibitor or an angiotensin receptor blocker. That reduction of glomerular filtration occurs at tubular glomerular feedback, essentially. That would occur in the absence of an angiotensin converting enzyme inhibitor or an ARB. But all of the trials, as went through on the prior slides, do show that that's occurring above and beyond that of the classic RAS inhibitors that we've been using, and that's important. And that reduction in glomerular hyperfiltration is not a new idea. That has been there since RAS inhibitors started to be used in kidney disease more than 20 years ago. But the SGLT2 inhibitors provide an additional benefit there. And that was very clearly shown, first I recall from the EMPA-REG study, but it was also shown in Credence. Anybody who does education for medical students or residents and wants to discuss what happens with initial drops in GFR and then eventual a slow decline in the GFR can literally take figure 2C or whatever it was from the EMPA-REG trial and prove that in a patient cohort, that's exactly what happens in the large patient population as what you're seeing in the individual nephron, that you see a reduction in GFR initially, but that slope of that GFR remains lower over time, such that you're better off in that arm than in the placebo arm. And I think that was an anticipated effect of these medications, but I don't think we appreciate, or at least I don't think we know all of the mechanisms by which SGLT2 inhibitors are working. There are currently a lot of theories as to how they're working in terms of energy utilization and reducing energy utilization for glucose. There are also theories that maybe blockade of proximal tubular sodium reabsorption in and of itself is a reduction in energy usage by the kidney. And that if you had theoretically started with another sodium transporter blocker for the proximal tubule, you might get a similar benefit. I don't think we'll ever know now because it'll soon be standard of care to be on an SGLT2 inhibitor, but that is another theory that has come up. And I think these mechanisms still have to be worked out because there are a variety of side effects of SGLT2 inhibitors that we have to be aware of. And the more these drugs are implemented over time, the more some of these things may come out. So there's some initial predicted mechanisms of action, which makes sense. And then there's a lot of things that have happened which you don't yet know. What you're showing on this slide in terms of mechanism of benefit are additional things that I think some of which was predicted and is borne out in clinical trials in terms of a very mild effect, but persistent effect on blood pressure that comes from blocking a transporter that is upregulated in diabetes, weight loss from the loss of from glucoseuria and the reduction in insulin secretion that portends. And then there's these other side effects that we still don't fully understand. So there's a reduction in uric acid, which likely comes from a reduction in urate-1 transport in the proximal tubule. There's also a rise in serum sodium, which is thought to be from an osmotic diuresis, and a reduction in magnesium loss, which we're looking at as far as a potential mechanism of action of the overall cardiovascular benefit. And there's also a higher red cell mass. And I don't think we quite understand fully the mechanism of this, whether this is simply volume depletion, probably not, or an effect on the proximal tubular cell that's making the erythropoietin that's leading to that red cell mass. And I think a variety of things that are happening with this single drug probably conspire to lead to the benefit that we're seeing. And it will take some time, I think, to tease out which of these are sort of the larger mechanisms of action and which of these are just the grateful side effects that we see with this therapy. So I think I'll pass it along to my colleagues for further details.
Yeah. So I think the one part that was very interesting that
Nothing really to add other than, I think
Yes, Muthu, you were saying?
I apologize. At the end of Emperor Reduced, there was a subset of the population, about 1,000 patients of the 3,700 that were randomized, that had a follow-up laboratory draw after the randomization phase. So this was looking at removal or withdrawal after SGLT2 inhibition is removed. And it really highlights, I think, the fact that initial EGFR dip is not only transient and stabilizes over time, it's actually reversible. And in fact, once you actually withdraw an SGLT2 inhibitor, you remove that pharmacodynamic effect on the glomerular pressures, and you're able to see a clear, unconfounded effect in slowing kidney progression compared with placebo. So I thought that was a very nice demonstration. We've also seen data from now EMPEREG and Credence that initial EGFR dip has no bearing on the subsequent cardiovascular and kidney benefits of these therapies. And so even patients with more substantial EGFR declines after initiation of these therapies in the 20% or 30% range still derive substantial cardiovascular and kidney benefits. So.
And I'll just add to what Muthu said, by that observation is the sine qua non of a hemodynamic effect. It reverses with removing the agent. So it's important to work out the other effects, but we know that this is a major effect, and it's really been beautifully demonstrated on the clinical side and lines up exactly with what we would expect based on the underlying biological mechanism.
The one thing I would add to that is the misconception that is still highly prevalent on calling this reversible and benign change in glomerular tension AKI. And one of the problems that results in the reflexive de-escalation of therapies, and this is not unique to SGLT2 inhibitors, this is very true with the use of renin-angiotensin system inhibitors, especially in the hospitalized patient and certainly also in the outpatient setting, where these minute fluctuations that are seen in the context of appropriate decongestion in the setting of acute heart failure, appropriate use of RAS inhibitors, and now the addition of SGLT2 inhibitors on top of these standard of care therapies. I think it's really important to educate the cardiology, the internal medicine community, and the nephrology community about that this doesn't portray harm. These are actually the intended therapeutic benefits that are accrued with the use of these agents. And to that end, I think one of the points we also make in the statement is there may be some utility, although this has not been tested rigorously, to the use of biomarkers of tubular injury to separate out benign changes in markers of glomerular filtration from these creatinine changes that may portray true kidney injury. So it certainly is not something that is used commonly in practice, but it is something to think about as we really try to implement these strategies aggressively.
Yep. Thank you. That was actually very comprehensive and covered a lot of different aspects. I think we'll come to the ketones in the end if we have some time, because I think there's an interesting hypothesis, sort of an advanced heart failure, that I'd like to get Muthu's thoughts on. So I think that brings us to the timely question, the adverse events. To really summarize, I think the big two that concerned me personally when I was sort of introduced to this drug and how I describe the side effects of this drug to my patients when I prescribe it. I think diabetic ketoacidosis counseling is something that becomes important in when I start a patient on this, and the risk for sort of mycotic genital infections, particularly among women, that comes through. So maybe Dr. Rangaswami, you could sort of tell us how you go over the adverse effect profile when you prescribe this drug to your patients. And then maybe the rest of the panel could comment on how they counsel against preventing some of these side effects, particularly when they're prescribing it to their patients. And I think we'll benefit greatly from what you guys, from your experience.
Sure, and I would love to hear my colleagues' thoughts too, because I think all of us have slightly different strategies when we try to explain these risk-benefit ratios. It is not uncommon for patients, this is not going to be the first drug where patients read the back of the label and come to you with a million questions or see something on TV. And especially when there's also collateral therapeutic inertia from other specialists where it isn't being pushed hard enough. That prescription rates come to a standstill in appropriate targeted patients. All the adverse effects that are listed here are real. They are fully explained, at least to a large extent, explained by some of the mechanisms of the action that Vivek just talked about. I think a lot of the risk of genital infections and urinary tract infections can be prevented with open counseling about genital hygiene. There was actually a poster that was presented, I believe, at the ADA, and Kathy, you can correct me if I'm wrong, where a simple, intervention at, teaching patients appropriate hygiene in the context of use of these agents was significantly able to reduce the risk of recurrent UTIs. I think it is really important to let patients know that it is important for them to be able to recognize signs of developing cellulitis or Fournier's gangrene, which I think would be a devastating complication. And I think a lot of it is just because of personal embarrassment, just because of the nature of that side effect, that patients are sometimes reluctant to share early symptoms with their clinicians. And I think having an honest discussion up front about the importance of letting them alert you when these things happen can really go a long way. Most of these infections tend to be uncomplicated. They tend to be easy to treat. In terms of risks for volume depletion, which comes up especially if using in older patients or in frail patients, there has to be a protocol, and I actually have a handout that I give to patients describing what to do on sick days. And I think this has been a model that has also been encouraged by the think tank at KDIGO and several other leadership organizations, the ADA too, to counsel patients what to do when they have GI symptoms, they have poor PO intake, they're NPO for a procedure, undergoing the stress of a surgery. So a lot of these can be prevented with thinking ahead and giving them appropriate education on what to anticipate. There have been pooled analyses of looking at the overall risk of UTIs, of Fournier's gangrene, and overall, while there are these definite side effects, when you look at it as a whole, the overall risk is not significantly elevated. And I think sometimes sharing that information is also helpful. This was also confirmed in two large database claims-based analyses, specifically for UTIs. And I would love to hear Muthu and Kathy's thoughts on the whole question about the amputation, which can be very scary to patients. When it was first reported, from the Canvas program to where we are now, where actually that amputation notation has been removed from the black box warning about a month and a half ago for canagliflozin, I think what we really understood is overall as a class, they appear safe to use when there isn't evidence of critical ischemia, open wounds, clear compromise of perfusion with a full risk-benefit analysis. And particularly those patients with some evidence of PVD are also likely the patients that may even benefit from these agents because of their elevated risk. So I'd like to stop there and maybe have your thoughts on how you convince patients and how you counsel them.
I thought that was beautifully done, and not much to add in terms of the comprehensive overview of the safety profile. I think the amputation risk, I will say that, to some degree, it's that's one of the issues that I've no longer actually specifically counsel on. I think that we have now 9 other randomized clinical trials that haven't identified that signal. The FDA has taken the totality of evidence and removed the black box warning. I think if patients come to me and ask me about it, I share that. And I also share that to interrupt or call me if they do have open foot lesions. But short of that, I don't dive into a conversation about amputation risk, because I think that the evidence at present is not strong enough to support that. I think from some specific aspects related to heart failure care, I think volume is central to that, especially with high use of diuretics. In general, I think the thinking has slowly evolved that likely anticipatory upfront changes in diuretics aren't required, and that we can make changes in follow-up. And so, but that does require some anticipatory conversation about close monitoring of congestive symptoms, weights, etc. I think the sick day rules are paramount, as well as interruption ahead of any planned procedure or surgery to lower risks of DKA. And that especially goes for as we kind of promote inpatient use, which I agree is an important site of care. I think we will see that is going to be an important site that we see DKA as well. And so that will be important to kind of introduce amongst hospital-based clinicians.
Thank you.
The only small thing that I would add with regard to the amputation risk is that patients with particularly advanced CKD are at higher risk for amputations to begin with. So in the Credence trial, when the report from Canvas came out, we initiated a foot care program, which was very simple and analogous to the hygienic issues that Dr. Rangaswami talked about, which is simply to advise patients for daily foot inspection before they put their socks on. Now, not everybody can see their feet, so if they have a household member or a partner who can look at their feet, that's a good idea. And then as a routine practice in clinic, simply asking them to take their shoes and socks off and just take a look at their feet, because especially people with diabetes often have a severe neuropathy, especially if they have advanced CKD, and they just don't know if their foot is injured. So we don't know if it was the foot care that mitigated the risk in Credence, or whether it's just was a random occurrence in Canvas. But that said, I think it's just a reminder that good foot care is part of good patient care. And it's really very simple. Look at the feet and ask your patients and their families to look at their feet.
Thank you. I have a little smart phrase in Epic. Maybe if you guys have any resources, you could email it to me, and maybe I'll put it out when we release the episodes, sort of combine everything together for our listeners and viewers if they want to use that in their practice. So moving on, I think, to the next slide that we have. I think we spend a little bit of time.
Hey, I just had one extra comment here.
Of course.
Hey, could I just put one comment on the prior slide, in addition to what my colleague said, and I agree completely. I think I want to come back to something that Dr. Tuttle mentioned earlier in terms of sort of resourcing this, because the reason I'm late today for this I was late today is because I was counseling patients on the use of SGLT2 inhibitors. That's literally the reason I was late. And it takes some time. If you're being honest with patients about, genital infections, that raises some eyebrows when you talk to patients about it, because it's a very acute effect, and you're playing the long game with these medications. And so it's something that we definitely bring up to patients before we prescribe it. It's something that I'm sure patients who might not have appreciated at the time we started the prescription, but then eventually read the back of a label, will want to talk about further. And it will take time, and it will take time to walk through the risk-benefit ratio here, which is obvious, but it will take time. And I think the other thing that becomes very important with regard to the side effects is, as Dr. Rangaswami alluded to earlier, the idea of a drop in GFR as being labeled as AKI is the fault of the medical community. I mean, it's the fault of a nephrology community that we have to educate our colleagues that this is an intentional drop in GFR, and that if they see another physician, and many of our patients that are eligible for these drugs see many other physicians, that they don't get misinformation about what that is to interrupt the potential for this drug for their long term. And I think that the risk of UTIs has to be a very real discussion about the actual events and what can be done to mitigate it. Because it's something that, in my experience, if patients hear about something like that from somebody who's not responsible for their care for either their cardiovascular progression or their CKD progression, it could railroad what we're trying to do. So I think this just goes to the idea of not only, in terms of how we implement this, there's going to have to be education for a lot of physicians who aren't prescribing these, but may have heard about these side effects through all the press that SGLT2 inhibitors have gone.
Yeah,
Exactly. It's a balancing act between counseling about very real adverse events and also counseling about and dispelling disinformation. And I think that from an education piece, as we now have 3 randomized trials that support data for this class in patients without diabetes, it's also important to recognize that many of these adverse events are not actually seen in those clinical trials. And so rates of serious hypoglycemia, rates of DKA are not present. These aren't adverse events that are going to be important in a non-diabetic population. And then similarly, genital mycotic infections are very few in number in that population, just based on decreased glucosuria. So I think that as new labels take place and as the indications expand, our conversations will also need to expand to be tailored to the baseline risk for some of these adverse events.
thank you, guys. So moving on to the GLP-1 agonists, and in a way, when we spoke about the SGLT2 inhibitors, we saw maybe more of a consistent benefit across different outcomes, be it cardiovascular death, be it heart failure hospitalization, be it renal progression. Maybe I could have maybe Dr. Rangaswami from the panel, without trying to go over all the 8 or 9 trials that are there, how you look at GLP-1 agonist as a class, and what kind of patients are you looking to start this drug on for their proposed benefits? Did you hear me, Dr. Rangaswami?
Sorry, I thought you were addressing one of the others. So yeah, I think you're right. And certainly when you look at it from the heart failure perspective, I don't think the same signal is true with the GLPs. Well, and as you just mentioned, there's a very, very consistent effect, particularly from the heart failure trials and also from key secondary outcomes with the SGLT2s. I think the renal protective effects largely rest on the reduction in albuminuria. And when you look at Dr. Tuttle herself, has been the PI of one of these major trials. And whenever you look at what actually drove the reduction of the composite endpoint, I think it's mostly the reduction in albuminuria. There is benefit with the patient with the atherosclerotic cardiovascular disease phenotype, and then it also then brings the question as to whether there is a role for combining these therapies in certain high-risk patients. My experience with the use of these agents is definitely way less than with the SGLT2 inhibitors, which I was an early adopter of. And as we were just having a smaller discussion prior to beginning this podcast, as Dr. Tuttle mentioned, the fact that they are injectables, in my mind, may be one of the reasons why there is hesitancy for cardiologists and nephrologists to embrace them. But as Dr. Tuttle was pointing out to me, that may actually be one of the selling points, because it does reduce pill burden. And it's a once-a-week injectable, and there is the hope that we will also see an oral version of semaglutide soon. So I really would like to hear also Dr. Tuttle's opinion on this. She has way more experience with this, certainly, than I do.
Sure, I'd be happy to weigh in. In the CV outcome trials, the main effect was on albuminuria, but remember that these studies in particular had people who did not have much, if any, kidney disease. So the first outcome that we could detect in a short-term trial is albuminuria. So that's our opportunity to show a treatment effect. In LEADER, and then just at the ASN, we presented combined data from SUSTAIN 6 and PIONEER 6. In patients with a GFR less than 60, they slope of GFR decline, which is not evident in people with well-preserved kidney function. So we're beginning to see a niche for these, that they may be good therapies for people later in the course of CKD. I'd point out that the effect on GFR slope in the group with the GFR less than 60 exceeds 1 ml per minute per year difference between the treatment arm and the placebo arm. And we know from data out of the CKD Prognosis Consortium that an effect size greater than 0.75 predicts an effect to prevent kidney failure. So the signal is strong. And Award 7 is really the best study we have. The primary outcome here was a glycemic outcome. It was an active comparator of dulaglutide to insulin. Glargine is basal therapy. But the main secondary outcomes were the GFRs and the GFR slopes. And actually both doses of Dula prevented GFR decline over 1 year. And again, the baseline GFR was 35. So these people were losing GFR in the insulin group. It was 3.5 and it was 0 in both doses of Dula group, both groups with both a higher and lower dose of Dula. And in the macroalbuminuric group, which was 50% of the patients, the GFR decline was 5.5 ml per minute per year, exactly what we'd expect. And it was also reduced to 0 in both Dula groups. And just today, actually, the exploratory analysis from Award on 40% decline or kidney failure published in Kidney 360. You have the, we had already presented it, so you have the hazard ratio there of 0.45, but in time to event analysis for the macroalbuminuric group, the hazards ratio for 40% decline or kidney failure, I mean, it's going on dialysis or getting a transplant, was 0.25. And the p-value went out multiple zeros to less than 1. Now, admittedly, it's not post hoc, it's exploratory, pre-specified, but everything's pointing in the right direction when we look at patients with advanced CKD. And in nephrology, that's an important niche because we have had very few therapies that we could initiate at CKD stage 4 that prevented kidney failure. I would submit that the data from Award 7, both the secondary and exploratory data, are very encouraging in terms of therapeutic development for that particular patient population. And it's now being tested prospectively in the FLOW trial, which is semaglutide versus placebo, and includes people down to a GFR of 20. In Award 7, we actually went to 15, but in any case, FLOW is enrolling very well. It's about 80% enrolled. I've used the term that I would submit that GLP-1s are nipping at the heels of SGLT2. I think that the mechanisms of action are complementary and distinct. So there's a potential for combination therapy. And again, with the nod and the clear appreciation for the high cardiovascular risk in these patients, I would submit that this allows us even to do a little bit of clinical precision phenotyping so that in a person at high heart failure risk, the SGLT2 would be the preferred agent. But perhaps in another individual who has more of an atherosclerotic disease risk, you may choose to use a GLP-1 based on that alone, but have pretty good, maybe confidence isn't the right word, but expectation that the kidney benefits will also be substantial in this population.
Thank you, and that was very helpful. Yep. Let me go to the next slide here. So, I think I won't spend much time on this. I think you guys already went over, that there is, and this is sort of supported by the 2019 European Society of Guidelines on Diabetes, the new 2020 American Diabetes Association standards sort of provide a clear role for initiating this drug early in the therapy of patients with diabetes. I do have a slide on the mechanism of action for GLP-1 receptor agonists. Maybe Dr. Tuttle and Dr. Bhalla, you could comment on how we're seeing this improvement in renal function among patients started on this drug class.
Sure. And this is another situation where the original results out of the CV outcome trials were somewhat of a surprise, so that we're in a sense retrofitting the science to try to understand the mechanism. But that said, while the main focus of drug development for GLP-1 receptor agonists focused on pancreatic effects to promote insulin secretion and suppress glucagon secretion, there are GLP-1 receptors present in the kidney, most predominantly in the endothelium, but also, at least depending on the laboratory, they are variably detected in the proximal tubule. And when I should also add that it's not just in intrinsic kidney cells, particularly in the diabetic kidney. There is a very pro-inflammatory response in the tubular interstitium, and there are macrophages and T lymphocytes that infiltrate, and both of those cell types have GLP-1 receptors. So we also have to think about the infiltrating cells, not just the resident cells. And when the GLP-1 receptor is activated by a GLP-1 receptor agonist, what we do know from preclinical models is exactly what's illustrated in this figure, is that cyclic AMP is generated, which activates protein kinase A, which has both effects to decrease oxidative stress and downstream inflammation, but also blocks the sodium hydrogen exchanger, which is why the location of the proximal tubule is actually plausible, because with these agents, we see a natriuresis, but from an entirely different mechanism compared to the SGLT2 inhibitors. So the natriuresis may be part of the reason that we see a small blood pressure reduction. And we've posited that the anti-inflammatory effect is likely to be the major driver of the GLP-1 protection at the level of the kidney. And I'll stop here, but would like my cardiology colleagues to comment on whether or not that might be a plausible mechanism for atherosclerosis protection as well.
Certainly, and I think we likely don't have time for the individual mechanisms that support the cardiovascular protection, but I agree. I think that there is definitely converging lines of evidence why there may be this. I liked your kind of proposed pathway of more precision towards patients with more atherosclerotic burden, and we do see patients that tend to be either go down one pathway or another and have recurrent cardiovascular events or recurrent MI. And this therapy may actually be better suited for that profile. Even if you look at the timing of separation of Kaplan-Meier curves, they do occur slightly later in terms of major adverse cardiovascular events. In LEADER, for instance, probably with the most substantial benefits, you see after a year, and that may support also slowing of atherosclerosis as a mechanism of action. So I agree. I think it's very intriguing to think that similar mechanisms, including on infiltrating cells in addition to resident cells, may be taking place in multiple organ types.
I have a question, Muthu. Are you aware of any studies that have looked at any imaging of the coronaries or any plaque burden on GLPs, and any guidance in terms of what you just said as a plausible pathway?
Yeah, it's a great question. So there are now coronary CT studies underway. They haven't yet reported. The challenge with mechanistic studies with atherosclerosis is that they do take time to, unlike heart failure mechanistic studies, which we can do on a very short period of time and get quick answers in terms of hemodynamic effects as well as LV remodeling. These coronary plaque, especially in lower risk populations, take time to accrue. And so we've seen very similar, for instance, Dr. Budoff is actually the PI of one of those trials. He just presented data for icosapent ethyl evaluating that on coronary CT, and a very parallel trial looking at GLP-1 receptor agonists. So I think we'll learn more. His particular trial is looking at subcutaneous semaglutide, and
Thank
should
you.
be very intriguing.
So I think, I know we ran over a little bit. I'll spend maybe the last 5 minutes going over some very critical questions and really the question at hand. I know Dr. Rangaswami, last time we spoke, you told me you have a cardiometabolic clinic at Einstein that sort of brings everybody together in the same place to execute a multidisciplinary clinic. And sort of, I wanted to get the panel's opinion on how do you get everybody to come to the same page, which is primary care doctor, internal medicine doctors, nephrologists, cardiologists, and endocrinologists to move forward in expanding use of this drug in the community.
So yeah, I can certainly share some of the practical challenges with that. It sounds great in theory, and it's very hard to implement for a lot of reasons. And I think it's important to understand what the local challenges are, because they're going to be very different from health system to health system. It's based on where a patient may live. It's based on the density of access to certain specialists. Muthu and his group have reported very nicely on the ratios of specialists to patients, incident type 2 diabetes, and they're so all over the place. They can go from 50:1 to 2000:1. And that itself creates barriers to access. There are patients that are underinsured or uninsured. There are also studies that have shown that Black patients with actually higher cardiorenal disease burden, and underinsured patients are less likely to be interfaced with these agents. So I think it's important to take stock of what the local milieu is. And that dictates to a large extent how this kind of an integrated model should even be constructed. Now, the ideal, when you tell somebody, it's a great idea to have a cardiorenal metabolic clinic, everybody visualizes this nice, state-of-the-art center where the patient shows up and they, breeze through all their different specialists, go home with a nice integrated plan in place, and all their prescriptions are taken care of. It is really hard to construct this for many reasons. It is hard to get approval to justify the financials, to have a dedicated space, to bring a patient, coordinate different specialists. Under current billing practices, you may actually end up losing money rather than even breaking even, or what the hospital hopes you would do, which is generating income. There will be the acute need for either an advanced practitioner or some kind of care coordinator or navigator to ensure that all the gaps are filled, following up on a patient, monitoring for adverse events, refilling prescriptions, prior authorizations. This is what actually takes a bulk of the time. So while this looks great in theory, it's very hard to implement. And we realized this the hard way after a year or two of struggling with this. What are more easily implementable models are, one, to have a cardiorenal metabolic committee. The committee itself, represents different viewpoints from cardiology, heart failure, endocrinology, the internist, nephrology, specialty pharmacy, dietitians, etc. They don't even have to directly be involved in patient care, but they can review panels of patients, at a certain pace, and provide guidance on who is eligible and who might benefit from these agents, even without a direct consultation, to people taking care of those patients. This was actually recently shown in one of our collaborators' cardiorenal care models in Liverpool in the United Kingdom, where they had this kind of an interdisciplinary committee that was helping oversee assessment, risk stratification, and recommendations just based on chart review and interdisciplinary discussion, without actually going through the logistics of actually bringing a patient to see those people. So that's definitely one tangible option, something we've started doing. The other one, which I'm a huge fan of, is inpatient implementation. I really think if one of these agents is introduced in the inpatient setting, the likelihood that it will first be continued into the outpatient setting is high. because people may have some inertia with starting these agents, but once it starts, they tend to continue them. And that's just the way physicians and clinicians practice. And I think, especially in heart failure, it is a great opportunity, especially in those with reduced ejection fraction, to try to optimally titrate, not just introduce SGLT2 inhibitors, but ensure they're going on appropriate doses of their other GDMT agents. And I think it's an opportunity that we miss way too often. So right now we're actually focusing more on the committee and also on inpatient initiation, to be honest. And I'd love to hear the perspectives of our other experts to see how they are working around some of these barriers that I just talked about.
Dr. Bhalla, maybe we could have you give your opinion on the other coast.
Yeah, I don't have much experience in the sort of cross-committee implementation here. I would say, just from my own anecdotal experience with the use of SGLT2 inhibitors, as well as my experience in doing multidisciplinary collaborations at an institution like ours, is I completely agree that it's much easier said than done. And I think that some of the pain points with regard to starting these medications is, I think, where we should focus our resources the most. And I think one of those, and at least initially, will be with specialty pharmacy. I could see it at an institution where you have essentially 4 different types of providers, almost who are aware of these drugs, essentially going to be competing for who starts it. It will be much easier if we have a centralized location for the prior authorization of these medications, because it's going to take some time, and the more familiar people are with getting these drugs authorized, the more likely that we're going to be able to roll them out much quicker. I also think the patient counseling part would also benefit from sort of a group-based counseling, and that could be in the simple form of smart phrases, but that also there might be ways to help implement that across specialties that really help us save time in clinic, because, as mentioned earlier, the side effects of these drugs take a long time to go through, and we're in it for the long game, and getting patients on board with that is important. So I would say those 2 areas are, I think, areas that are going to be fruitful, at least initially, as we try to roll these drugs out. And one last thing I'd like to say is I'm looking forward to this. It's not often, there's a cardiologist on the line here, and I'm married to one, but it's not often that nephrology and cardiology are aligned in a goal, right? I mean, for years, we're working with cardiologists, and one of the primary therapies for heart failure is antagonistic to the kidneys. And so to be aligned with cardiologists for the same goal is just something I'm looking forward to. I'll leave it at that.
That's remarkable. I think, I will echo Johnny's initial comments that the high-level barriers, logistical barriers, sometimes are we on the ground level, clinicians aren't aware of or may not pay attention to. Inpatient formularies are something that I think still, like many, do not have SGLT2 inhibitors, or not all SGLT2 inhibitors on formulary. And so as labels actually evolve, I think it'll be important that inpatient formularies also follow suit, especially for the indications where you think you're going to be starting these therapies for during kind of acute hospitalizations like heart failure. We just got, even though dapagliflozin was approved in May by the FDA, we only got the drug on our inpatient formulary this last month. And so it took a long time, even with other focused implementation efforts, people just couldn't logistically start the drug. The other is that local counties vary drastically with respect to the preferred therapy, local therapy, and for most of our large insurers in the United States. And so that is something to just be aware of locally and practically, I tend to lean towards the SGLT2 inhibitor when labels are, for instance, for type 2 diabetes, I tend to lean towards therapies that are generally going to be with greater coverage. And so, geographically, that varies dramatically. And I think it's good to know what your local coverage schemes look like. And then the last is something that, we'd mentioned this recent viewpoint that we talk about some of the multi-level initiatives that are needed to promote these therapies. And in part, I think there needs to be incentives that align clinicians. I think, Dr. Bhalla, I think is probably a unique clinician that looks forward to initiating and continuing care. And I think that ultimately clinicians also respond to incentives. And at a policy level, a lot of our incentives aren't favoring the extra time that it takes for counseling and promoting use. If you take, for instance, Medicare Advantage, Medicare Advantage has several incentives built in to promote chronic care, such as diabetes and heart failure. But the incentives were built and designed based on a decade ago evidence base. So it's promoting issues like eye exams, glycemic control, foot care, which is very appropriate, but hasn't caught up to the more recent evidence base that we have true organ protection risk lowering. And so if you compare, for instance, a Medicare Advantage population to the overall Medicare fee-for-service population, they have markedly lower rates of use of SGLT2 inhibitors and GLP-1 receptor agonists. So the incentives clearly do drive how clinicians ultimately will behave in practice.
Yeah, thank you. Those are great points. So I know you guys have been very generous with your time. I do have a lot of questions. I won't go over them. What I probably will do is maybe I'll put some of these over on Twitter, and I'll let most of you guys sort of answer them on Twitter. Makes it easier that way. Thank you so much for your time, everybody. Any last words, any concluding statements? Floor is yours.
Well, thank you so much for doing this and for having such a variety of different experts and specialists come together. I think this is the model we hope to recapitulate in clinical practice. It's one thing to have us talk about the right thing to do, and it's one thing for us to assemble and actually do the right thing. And like Dr. Tuttle likes to say, the SGLT2 inhibitors in particular, they are the gift that keep giving, and it's about time we actually showed some of that translate into outcomes outside of clinical trials. And as Vivek is also very fond of pointing out, after this drought for 2 decades, we have this plethora of therapies now in kidney disease, and it is poised to have a very transformative effect. And I really think this couldn't be a better time, for us to be in this space, helping our patients. And a big thank you to all my, awesome co-authors for their help with this scientific statement. It was one of the best collaborations, I've ever worked in, and thanks to everybody.
Thank you, Mehak, and thank you, Janani.
Thank you.
Thank you for bringing us over. This was a terrific discussion.
Yes, thank you very much. And much more to come.
Much more to come. Thank you so much, everybody. And thank you for your time.
Take care.
Thanks. Bye.